In fact, my talk today is about precision medicine, which is tailoring treatment to the individual patient, encompassing a multiple data-driven and multi-omic approach foster accurate clinical decision-making. In fact, the very important dream for all of us who are working in the IBD field that to tailor medication to the patient and to prospect the effect of the medication and to know whether this patient get benefit from the medication, whether conventional or biologic or not. And actually, it is a dream for us because you know the cost of the medications. And in fact, as we will see, the first biologic is the very effective biologic if you are in good choice, but this usually is if you are using the biologic after failure of the first one, it is a little bit having a less result for the treatment. The idea of the precision medicine would have significant benefits, enabling timely therapy that is both effective and appropriate for the individual. So now we have three limbs: time, appropriate, and the to tailor the medicine. Increasing biologic and the small molecule therapeutic options are available, but loss of response is common. Precision medicine in IBD with the aim of tailoring the right therapy to the right patient at the right time on the basis of an individual patient biology is an aspiration. Broadly, it appears that etiologic factors concerning around the genome, exposome, microbiome, and immunome. An integrated approach is needed for true understanding of an individual patient's biological and pathogenic mechanisms and thus therapeutic option. So these multiple omes, we have to deal with these multiple omes, and this is what's called the multi-omic approach. It is also becoming clear that the first biologic therapy, as we said, seems to be the most effective with dampening using the second. The ability to predict the response, relapse, and side effects as well as optimizing drug level and early identification of loss of response is highly desirable. The development of biomarkers enable targeted and effective individualized treatment necessary to allow selection of right drug at the right time with the right patient. Multi-omic approach is the one we have to approach through exposome, genome, immunome, and microbiome. First, genetics. The observation that the risk of developing IBD is greater in people who have relatives with IBD suggests a genetic component. Genome-wide association studies, which is GWAS, have facilitated the discovery of a large number of significant genetic risk loci. Many loci are shared between ulcerative colitis and Crohn's disease and may overlap with loci associated with other inflammatory disease. Functional gene polymorphisms are known to impact on innate immunity, adaptive immunity, and regulation of the intestinal barrier. As we know, the intestinal barrier plays an important role in pathogenesis of IBD. Environment, which is exposome. The industrialization and westernization of population affected the IBD. Again, early life events, pollution, and diet have all been implicated in the development of IBD. Microbiome. The dysbiosis seen in IBD has been well described as being characterized by a reduced diversity, expansion of facultative anaerobes, and decreased number of obligate anaerobes. The immunome, as you know, the gut is a crucial immunological interface that maintains immunological balance. Appropriately recognizing and tolerating commensal bacteria, food antigen, and self-antigen, which is what's called tolerogenic response, identifying and acting against pathogenic organisms, which is called immunogenic response. This regulation immunological balance within gut leading to imbalance in pro and anti-inflammatory pathway with the resultant occurrence of IBD. Impaired barrier function, again, of the epithelium coupled with epithelial neutrophil accumulation defective antigen clearance by macrophages, and impaired conditioning of the dendritic cells are all innate immune factors thought to contribute to the persistence of inflammation. Concept of precision medicine in IBD is to tailoring the medical treatment for individual characteristics of each patient. Predicting disease susceptibility and the clinical phenotype. GWAS have provided important insight. They found 240 genes in IBD. Some GWAS associations have been associated with distinct clinical phenotypes. NOD2 and CARD15 is involved in pattern recognition receptor signaling in response to microbial signaling and has been associated with ileal disease phenotype. So if you found these genes, suspect ileal fibrostenotic lesion. NOD2 and CARD15 has also been associated with need of surgery and complicated disease course. So you can imagine what will happen for the patient once you have the gene map of this patient. ATG, glycated effective autophagy, as an important part of Crohn's disease development, has been associated with ileal disease. So also the gene you can allocate the site of the lesion or the site of the suspected lesion by knowing the gene of this patient. Another autophagy gene, IGRM, has been associated with penetrating disease. So the course of the disease, you can predict the course of the disease, which will be either stenotic or penetrating or which of which. IL-23R, which has become successful therapeutic target in Crohn's disease, also has been previously to ileal Crohn's disease. I know this is some sort of heavy lecture, but we have to simplify as far as we can. The microbiome have a role to play in helping identity of high-risk individuals. Ileal microbiome signature, there is something called microbiome signature, was found to be predictive of Crohn's disease even in the absence of overt inflammation. Now, how can we predict the course? Some clinical parameters may predict the course of the disease. Clinical parameters include in Crohn's disease, age below 40, need for steroids in the first flare, perianal disease, upper gastrointestinal lesion, ileocolonic lesions, and within 10 years of diagnosis, if the patient below 40 years, upper gastrointestinal lesions, structuring or penetrating and terminal ileal lesions, all of these predict unfavorable course of Crohn's disease. In ulcerative colitis, within 5 years of diagnosis, younger age and female gender have unfavorable course. Within 10 years of diagnosis, younger age, female gender, fewer systemic symptoms, extensive colitis, non-smoking status, all of these are predicting unfavorable course of ulcerative colitis. Some markers well known and we use, like fecal calprotectin, have shown to be associated with need for colectomy in ulcerative colitis more than the others. Similarly, fecal calprotectin show to predict the progression in Crohn's disease behavior, hospitalization, and the flare and need for surgery. Furthermore, the reported prognostic performance of fecal calprotectin is similar to that of other non-specific blood markers such as C-reactive protein. Lee et al., who explored the CD8 T cells transcriptomic profiles in newly diagnosed IBD, identified unique RNA signature that were associated with the need for the treatment escalation or surgery or both over time in both Crohn's disease and ulcerative colitis. The UK IBD GC identified 4 prognostic genetic loci, FOX3 and the NTC region. These genes were distinct from those that predict the disease susceptibility. As you see, all are concentrating on the genetic mapping of the patient to predict the course and to predict the behavior and to predict even the type of the IBD. The molecular picture of disease course has been further defined beyond genetics at methylome and glycome, other OMs, methylome and glycome, and protein level. These studies showed that patient with an aggressive disease course display unique methylome and signature, including markers such as serum calprotectin, serum and fecal calprotectin that predict treatment escalation or surgery. So they found other omes they are acting on, and they measured the serum calprotectin as well as these methylome and proteome to predict the course of the disease. Glycomic markers have previously been shown to be associated with IBD and more recently have shown the ability to predict treatment escalation. This is called glycomic markers. In clinical practice, tailoring early top-down therapy, this, if you remember the top-down approach and top-up approach, the top-down approach therapies in those patients with disease avoiding short therapies in those with a benign disease course of diagnosis is a unmet need. Real unmet need to know whether your patient will benefit from top-down or top-up approach. Microbial population have a role in helping predicting disease course as illustrated in post-operative recurrence in Crohn's disease. Microbial signature again can predict the course of the disease as well if you have the microbial signature like these bacteria. If you have a microbial signature, microbial signature at the time of diagnosis were found to help predicting 6 months steroid-free remission. Now, how to personalize the therapies in inflammatory bowel disease? The goal of precision medicine is to enable perfect choice of the drug for the patient, for the individual patient in the exact time. They found that NOD-T15 polymorphism is known to be associated with the onset of thiopurine-induced myelosuppression. You can predict that your patient will have thiopurine or thiopurine side effect have this gene inside. Again, HLA type has also been demonstrated to be a predictor of side effect of thiopurine therapy. An association with pancreatitis developed with as a thiopurine was found linked to HLA-DQ-A1 and HLA-DRB1 alleles. This can predict that this patient may have pancreatitis with you as a thiopurine. In fact, if you have the measures of TPMT and the end product, you can monitor the therapy whilst you are using the azathioprine. But if you have these genes, the typing, you can predict the occurrence of other side effects like myelosuppression in progress and also the pancreatitis before you start your medication. Similarly, now we can measure the TDM of the biologics, rough drug monitoring, to enable to know whether this biologic will continue its effect or will lose its effect. Accurate pre-treatment prediction of response to biologic therapy would enable better drug selection for patients. Currently, there are no clinical available biomarkers that accurately predict treatment response. High expression of oncostatin M, OSM, a cytokine, is associated with a reduced anti-tumor necrosis factor. They can measure this expression to know whether the anti-tumor necrosis factor is loss of response or not. Another, low serum expression of triggering receptor expressed myeloid cells, TREM1, measured prior to commencing therapy, ablemactinib, is an accurate anti-tumor necrosis factor specific marker for further anti-tumor necrosis response with endoscopic remission in both Crohn's disease and ulcerative colitis. This telescope identified and validated 13 gene signatures that predict week 6 mucosal healing response, and Morella identified and validated 9 multi-omic signatures in colonic ulcers in acute severe ulcerative colitis, successfully classifying responders and non-responders to corticosteroids. Another prediction response of biologic therapy using microbial of patients with IBD has also been a focus for investigation. Fecal microbial diversity resembled control in predicting patients who responded to anti-tumor necrosis factor therapy compared with non-responders. Also, they found that distal gut microbiome of Crohn's disease patients who responded to anti-integrin therapy compared with non-responder having different microbial signature for anti-integrin, and for Stephen Lab also found that at week 6, therapy, patient in remission could be distinguished from those with active disease by characterization of their microbiome. Recently, results from this study in Crohn's disease were published. They has also presented data showing that HLA variant determine anti-tumor necrosis therapy immunogenicity, and the branch N-glycan in colonic biopsies patient with ulcerative colitis were predictive for failure to respond to standard 5-ASA and corticosteroid and immunomodulator. This may lead you to start with biologic in the start. The only other independent predictor of failure is CRB and N-glycan. This combination of N-glycan and the CRB level were combined in all ulcerative colitis. They can predict the response to treatment. The gene signature in recent studies have used signal gene expression technologies in order to better understand the molecular pathophysiology of the drug. They found that intestinal epithelial depletion of this gene has been shown to negatively impact a mitochondrial function with subsequent epithelial barrier dysfunction, and which is a feature of ulcerative colitis pathogenesis. They also can identify gene signature for those who respond to anti-tumor necrosis factor or anti-integrin therapy response. You can monitor your response through, as you know, the concept of treat to target is our aim, and this treat to target, our target is mucosal healing. So we can, in Crohn's disease, we can select a therapy for target of mucosal healing. However, sometimes we cannot reach this mucosal healing except after we have several multi-approaches, the endoscopic and histologic and radiologic and biomarkers. They found that transcription of these genes were demonstrated to be most associated to endoscopic disease activity, and the above factors were also shown to decrease the association with a reduction of endoscopic disease activity after 14 weeks of anti-tumor necrosis factor treatment in ulcerative colitis. Glycoprotein acetylation is another example of a novel biomarker when compared to fecal calprotectin and CRB, and in fact they found that it's economically the same as CRB that can predict or monitor the therapy during treatment of ulcerative colitis. Restoration of microbial diversity of patient has been explored as a potential biomarker to assess response to therapy. Restoration of gut microbial diversity has been seen to anti-tumor necrosis factor increase. And this diagram show you what is the multi-omic approach between genome, exosome, and microbiome and immunome. And this diagram shows how to know our target. Existing biomarkers like CRB, fecal calprotectin, antidrug disease, potential biomarkers which can predict the course before you commence the treatment, like exosome, genome, epigenome, transcriptome, microbiome, immunome. Stratification of the and prediction the course of the disease throughout this map. You can, by this, can have what's called the precise medicine, which in conclusion needed to know which time you can give the patient, which patient and which drug. Significant progress has been made towards the goal of precision medicine in IBD. Still a substantial unmet need for further biomarker, which to stratify patients and their treatment. It is vital that we continue to develop existing practice by assembling advances in knowledge whilst optimizing novel and existing biomarkers to continually make advances towards truly individual care. Precision medicine will require not only the knowledge, but the tools and the infrastructure with which to implement effectively. And thank you, and I'm sorry for exceeding my time.